Good afternoon, everybody. This is Kevin McGinnis for the National Association of State EMS Officials and your host for the Community Paramedicine Insights Forum, our January 2017 show, along with Gary Wingrove from CLEAR, who is doing all of our technologizing today. We are pleased to be able to bring this session to you. As you probably know, since you signed up for this through the CPIF.communityparamedic.org site, on that site we do have an archive section which houses all of the sessions we've had for the last 5 years, and we will be adding this one to that just afterwards. We've had a little bit of holiday interference this year. So we chose to do today's session, though it's Martin Luther King Day, and we realize some folks will not be able to be on. But with the archive feature, people should be able to go ahead and see the show at their leisure. Next month, we are going to not have a Community Paramedicine Insights Forum since, again, it's interfered with a generally state-recognized holiday of President's Day. But we will be coming back on March 20th for our March show, and it's going to be a doozy. We will see you back at that point. And speaking of doozies of shows, we are really pleased today to have with us Andy Gienapp, who is the EMS manager for the Wyoming EMS office. Andy has been in EMS for 28 years. Has held a variety of positions in EMS and set out on an adventure about a year or so ago, a couple of years ago now, to become a state that proactively took community paramedicine by the horns and wrestled it into actually a regulatory approach to enable it. We've seen a variety of different mechanisms that have had to have been used in various states for either legislating community paramedicine into being and or just enabling it using current statute. Andy and Wyoming took a bit different approach of taking existing statutory enablement, but in introducing a comprehensive, and I will say this is the most comprehensive regulatory approach I've seen to community paramedicine enablement anywhere in the country to date. And that's why we wanted to have Andy come on and share with us his experience in getting that to happen. It was not an easy project or process, as you can imagine. But it was successful, and I think has really set a template for others who might want to follow down that road. So without further ado, I would like to introduce Andy Gienapp and have you take it away.
Thank you so much, Kevin, for inviting me to present this, and Gary for helping me out. I'm recovering just a bit from a cold, so if I sound a little raspy, I hope you'll forgive me, and you can feel free to ask me questions later. I think I've got my contact information in there. Just real quickly, I'll tell you that despite all of the roles that I've served in EMS, none of them have been actually as a community paramedic. So what I'm getting ready to lay out for you, I've never actually done in the field myself. But I came to Wyoming from Tennessee coming up on almost 7 years ago now, and assuming the role of the state director and having paid attention to the development of community paramedicine across the nation, the handwriting was on the wall in terms of that this was something that the state Wyoming was going to have to consider, that our EMS profession is going to have to consider, and we started to go after it. In 2011, many of you are familiar that CMS opened up the CMS Innovations Grant, and many of the applications for grants under that program were for to do community paramedicine projects or similar activities. I immediately jumped into that and thought, wow, this will be the way to really launch this off in Wyoming if we can get a CMS Innovation Grant. What I quickly ran into was that it was way bigger than I had first imagined it to be, and quickly determined that we had some legal and regulatory obstacles that had to be overcome before community paramedicine could be a thing in Wyoming. So what I'm hoping to lay out today, I hope that it is all that Kevin just described. We'll see as this develops in Wyoming. But what I hope to lay out for you today is just kind of what I was able to work through with the help of many others, not the least of which were Kevin and Gary themselves, who kind of mentored me and read a lot of documents, and we shoved things back and forth via email, and they gave me input. So I would be remiss if I left Kevin and Gary out of that mix and didn't acknowledge their contributions to what we've got going in Wyoming. So I'm just going to walk you through, and I laid out these kind of objectives, my bottom lines that I want you guys to be able to take away from this when we're concluded with this presentation. I want to lay out for you why I think this is so important for this to happen in Wyoming and in the other rural states. We're going to talk through some of the particulars about what Wyoming was confronting and how we kind of worked around it. What were the solutions that we came up with? And then hopefully somewhere down in there you'll see some of the secrets to success that may be applicable as you work on this in your own states and work through some of these legal problems. They won't be exactly the same because every state is different. There's 56 different ways of confronting this, but hopefully there's some big nuggets in there that you can take away and apply in your home. All right, so why bother? Most of you are familiar that as community paramedicine developed and kind of came to the forefront, it faced resistance from any number of areas, from other healthcare professions and other healthcare delivery partners to the actual statutes or the regulatory hurdles. Sometimes it was active resistance in terms of, we don't want this to come in. We think it's a bad thing for our citizens, for our patients. And sometimes it was, which is what I really think was the case in Wyoming, it was the biggest thing that we ran into was just that nobody had thought about community paramedicine when they started setting up the EMS system in Wyoming. So why do we go down this regulatory and statutory route? Well, because in EMS we constantly deal with a lot of legal ambiguity. Whose license am I functioning? Can I cross that state border? Am I practicing medicine or not practicing medicine? All of those things. And so as I looked at community paramedicine in Wyoming, what I really wanted to do with the rules that we developed was to lay a foundational legal groundwork where our EMS providers would know that they were acting and standing on solid legal language as they started to do this. So I'll tell you just a little bit about Wyoming because I think it's relevant to the discussion, and I always enjoy bragging about my state and kind of opening everyone's eyes to what's going on in rural America. So here's just some hard statistics for you to look at. We have 97,000 square miles and population density that is only 5.8. We're the least populated state in the union, and we rank only behind Alaska, but that's just because Alaska's got so much territory that they don't know what to do with up there. So we're a very big state, and the population is very spread out. Of the 23 counties in Wyoming, only 2 are considered to be urban, 4 are considered to be rural, and the rest are considered to be frontier. So that's kind of the geographic layout of how of our state. Our workforce in EMS is what's depicted here. You can see that far and away that those functioning at the EMT level, what was previously described as a basic level, they represent the majority of our EMS workforce. We have very few paramedics in the state, and of that 517 that you see represented there, a lot of those are affiliated with the flight services that come in and out. So the number of folks, of EMS providers that actually live in the state is very small compared to many of the other states. So that was relevant in how EMS happens across the 23 counties and 97,000 square miles. Just healthcare-wise, here's some other statistics to kind of show you the hill that we're climbing up. We have only 26 hospitals, and of those 26, 16 are designated as critical access hospitals. We only have 2 hospitals currently that have a designation by the American College of Surgeons as level 2 trauma centers. So what we don't have is more significant, and what we don't have is any comprehensive stroke centers. We don't have comprehensive, STEMI centers. We have only the 3 interventional cath labs that are operating 24/7. We have no burn centers. We have no pediatric centers. You name it, and we probably don't have it. So what that means is that for our acutely sick patients that EMS transports on a day-to-day basis, they're often required to go out of state to seek some of that definitive care that's become the standard across the nation in terms of treating illness and injury. So we have a lot of challenges and hurdles to overcome. But it doesn't end with just the acute patients. If you look at the other bullets that I have on the slide there, you'll see some other factors that, only 166 physicians providing direct patient care per 100,000. 226 is the national rate. So we're somewhere around maybe just a little better than half of what the rest of the nation is experiencing. Our physician workforce is aging with a mean age of 52. That means that presumably within the next 10 to 15 years, we're going to see a large portion of our current physician population looking seriously at retirement. And then that down at that bottom, when it's that bullet that's talking about the need for 30% growth by 2030, just to maintain the status quo. That's a troubling factor when you consider how nationally Wyoming and the rural areas are seeing the population leave. It's hard for a rural area to compete to draw in primary care physicians and develop resources. Yet the demands are still the same, and they're still there. And that picture up there, I thought I'd just included that on this slide. That's a picture of the clinic that's in Pinedale, Wyoming. Sublette County, which is where Pinedale, Wyoming sits, very large county, and they do not have a hospital. So despite the fact that actually looks like it might be a hospital, it's not. And there is a fairly significant population in Pinedale in Sublette County that has to get access to health care. So as a state or EMS director, you're looking at that thinking, well, how in the world do we continue to get primary and acute care to a very sparsely or a very spread out population? But so as you look and you consider that, down at the bottom, then you see that other statistic that I just did in there with simple math, which is that conversely, we have 391 EMTs per 100,000. Wow, that's really great. That means that our EMT to population ratio is better than our physician to population ratio. Except for this twist that in Wyoming, nearly 74% of our total EMS services are delivered by part-time or only partially compensated or completely volunteer workforce. So those are large challenges to overcome in terms of delivering care. But I was very thoroughly convinced that we had to make an attempt, and community paramedicine is part of that solution. So here's what we immediately ran into. I can guarantee you that this is, if you're experiencing issues in your state with trying to figure out how do we make this happen, many of you are confronting the exact same thing, that the EMS acts that gave the authority to create EMTs, paramedics, and ambulance services, they were all adopted about the same time, and nobody ever envisioned EMS doing what we're talking about when we talk about the role of the community paramedic. They just didn't contemplate it. Never thought it would be that we would be having this discussion that we're having today. EMS was about answer the emergency call, go out on the highway, pick the patient up, and take them to the emergency room. That's what we were. And now we're talking about something completely different. So there is no language in Wyoming statute that says this. Some other weird issues that may be going on that are going on in other states. Through the way that the rules were constructed and through the statute, the EMT license was tied through the affiliation to the ambulance service. So in other words, when I came to Wyoming in 2010, you essentially could not be an EMT unless you were with an ambulance service. Well, that immediately precludes some of what we're talking about when we're talking about community paramedicine. The attendant versus non-attendant thing that we ran into in statute, that also created confusion because why did the legislature feel like it was important to make that distinction? And then finally, within the statute itself, we only had the authority to issue one kind of business license, and that is the ambulance business license. So we had a whole string of issues that were working against us in terms of whether or not we could allow EMTs and paramedics to fill these roles and go out and provide the kind of care that we want to see from community paramedicine. So we had those two things. We had an outdated statute and we had our own outdated rules, and they were both working against us in trying to get this going. So what are we going to do about it? Well, the state offices of EMS, just like any other state department, we don't have the authority to change the statute. I can't just go in and insert the words community paramedic into 33, 36, 101. Only the legislature can do that. Excuse me. So how do we create that authority and regulate it when none of that appears in statute? Well, okay, so you go back to the legislature and get them to change the statute. Well, except for this problem, which is that there is a fairly well-founded concern about opening up any kind of a practice act, whether it's an EMS practice act, physician or nurse, whatever the case might be. That starts to make people really nervous because not unlike much of the rest of our national politics, anytime politicians get into a law and start mucking about, you run the problem of ending up with something better. Maybe you end up with something better, but maybe more problematic is you end up with something that might be worse. So there's always a concern about whether or not we're going to go back in and crack open an actual statute and go to tinkering with it. So start looking at it, what solutions can we work on? Well, most certainly can go after the rules. And we started eliminating those barriers in rule that we could in terms of the requirement to affiliate. It's a horrible idea anyway, as a state regulator, I'm fully convinced of that. An EMT or paramedic license should be viewed as the license of the individual. This is the way that other licensed healthcare professions view their licenses and that profession. And I thought that was, I think that that's fundamental. Just because I don't work on an ambulance doesn't mean that I'm not a paramedic. I realize I don't actively touch patients anymore in my current role, but I very much am a paramedic, and I think that there are many across the profession that are engaged in educating or community paramedicine or working in regulatory roles, whatever the case might be. That's all part of the profession. It's just application in a different way. But the bigger thing that dawned on me as I was working on this was that second bullet under there, 351801. And I think this is one of the big takeaways that I want you all to hear from me as we come out of this. So if we look at the original Wyoming Practice Act, which was 3336, none of that language appeared there. But as I was scratching my head and beating my head into the wall trying to figure out how we could do this, I kind of re-stumbled onto 351801, and I'm going to talk to you just a little bit about that on the next slide. But the bottom line is that I looked for another authority that I had beyond the EMS Practice Act, and that was really fundamental to making the argument for why this could happen in the state. And tied along with that, what I was able to argue was the intent of the legislature. What did the legislature really mean, and what did they envision in 1977 as they wrote the EMS Practice Act? So, looking at 351801, which is actually the act that established the trauma system within Wyoming, if you look at that first section, 801, and it's a very short act. The Trauma Act is only about 5 sections long in Title 35. But for some reason, this sentence appeared: the Department of Health shall develop a comprehensive emergency medical services and trauma system. And it was at that point that I kind of had an epiphanal moment where I said, okay, I've got the authority under the legislature to write rules as it relates to 351801 as well as to the EMS Act itself. And here the Department of Health has told me quite clearly and quite unambiguously that we need to develop a comprehensive EMS and trauma system. So then it was a simple short connection to try to make the point that when you take the role of the community paramedic as it's being developed right now and is kind of evolving, where we're looking at reducing the burden on the emergency medical system that's impacting 911 and impacting our nation's emergency rooms, well, there you go. Now I've got a comprehensive emergency medical services. And hey, if that is true, legislature and all parties involved, if that is true, then it is also true that community paramedicine that is designed to go after healthcare problems proactively and avoid readmissions through the emergency room or readmissions into the hospital because of something that can be taken care of elsewhere, then that is all beneficial, and that's all part of the comprehensive emergency medical service system. And the people that deliver that are the EMTs and paramedics of Wyoming. And so so we do have the authority to create this. And that was really kind of the breakthrough moment for Wyoming, was to be able to make that argument. As it relates to intent, this was kind of an interesting construct as well, because that second sentence there, persons not serving as attendants may be trained and certified as emergency medical technicians, have certification renewed if requirements are satisfied. Well, that appears in the EMS Act. So as I looked at that, I said, well, why in the world would the legislature make that distinction? If on the one hand they're saying people that are serving as attendants and working in the back of an ambulance, if you're saying that those people can be trained and work and provide care, then why would you bother saying that people that don't work in an ambulance can also be trained and provide care? Because if they can't provide care, then there's no point in them being trained, right? So I was able to take this section of the Wyoming statute and successfully argue that no, actually somewhere in the chronology of Wyoming's EMS history, the legislature recognized that there was a need for people to be trained and certified and licensed as EMTs, even if they were not in the back of an ambulance. So by taking some of the things that existed in two different places, in the EMS Act and the Trauma Act, we were able to make this argument to say, no, we have the authority to write rules about this, and we have the authority to allow these people to function. So I won't belabor this one too much, and I hope that I don't insult anyone's intelligence when I run through this. But I think this is important for the EMTs and paramedics, the community EMS providers, community paramedic providers of the world to understand that and perhaps offer a limited defense of the bureaucratic state offices and the beleaguered bureaucrats like me that run those places. If there is resistance at the state level or some questions being asked from your state EMS office, understand the kind of environment that they are working in. They can't simply go out and wave a magic wand and make it happen. So the authority to act, the state offices have no authority to act unless it originates in the state's legislative body, and that's where we get these acts that you've heard me mention already: Medical Practice Act, Nurse Act, whatever your EMS Act is. Usually within that legislation, the legislature will then delegate that authority to promulgate those rules and regulations to another entity, and that's the way it works pretty much across the board, whether it's EMS or your Department of Transportation or whatever departments may exist in your state. So now that you have that authority to act and the authority to write those rules, that state office is now able to promulgate those rules. And once those rules are out there and adopted, then they have the force and effect of law. That's because, as a Civics 101 lesson, no one elected folks like me. I was hired in to do my job. So there has to be a process in there where anything that we lay down that has the force and effect of law gets reviewed, and that the public has a chance to say, well, no, we don't agree with that. So in Wyoming now, in terms of that process, that if any time that a rule is ready to go, once that rule leaves my office and goes out to the public, it's about 130 days for the completion of that process, and that's assuming that nothing runs off the rails while you're doing that. So the point that I'm making is that, as it relates to this, is that it is a very long process to get this done, and that can be frustrating for those that don't live in this regulatory world that I do. And I'm asking you to understand what your state offices are doing as they're working through that and kind of what they're negotiating. Because what you don't see on that 130 days is the amount of time and the emails back and forth and effort that went into to drafting all of this with folks like Gary and Kevin and whomever, and then working with the Attorney General's office to get something finalized and pushing that out to where you can actually function on it. So just a note there to say this is not an easy thing to do on anything really related to the development of EMS. That's what your state office is up against in moving this up. All right, so in Wyoming, what we created through rule, I titled Community EMS. Why did you use that title? Well, as Gary and Kevin are much more capable of speaking to the issue than I am, mobile integrated healthcare, that term for a while was kind of used synonymously with community paramedicine, and it's kind of now defining itself as something else that involves many other healthcare professions, whereas community paramedic and community paramedicine are that's kind of where EMS, traditional EMS, is kind of living and developing in their role to this. And I never talk about this that I don't give a nod to Gary Wingrove as it relates to the term, because he certainly endorses the application of the term community paramedic, and I think he has solid reasons for why he does that. But in Wyoming, what I felt was important was to adopt a term that was just as absolutely inclusive as we could possibly be, because what we wanted was to be sure that everyone understood that this is the functioning in these roles are important and available to everybody, from that, whether they're an EMT, an advanced EMT, an intermediate EMT as defined in Wyoming, or a paramedic. So I went with the term community EMS. So what else did we manage to work out in the rules? Well, we created 2 levels, and this again was based on a lot of good counsel and mentoring that I got out of Gary and Kevin. We divided this up at the community EMS technician and a community EMS clinician. So broadly, what those 2 levels do, the the technician level is maybe a little bit more approachable for some of our smaller agencies. It's heavily geared towards strictly dealing with the impacts on the 911 and emergency systems. Less hours in terms of both classroom and clinical approaches. And the community EMS clinician, on that side of the house, you're getting a little closer to you're way more closer to the kind of the broader concept of what's behind what's usually connected with community paramedic, where we're talking about the proactive approach in reducing readmissions and working with primary healthcare providers and that sort of thing. So when you see that, that's kind of a really high-level overview of what those two levels are. The individuals themselves, the individual EMT or paramedic, completes one of the training programs, whichever one that they enroll in, either the technician or the clinician portion, and then they seek endorsement from my office as one of those two areas. Then the agencies themselves have to also apply and say, so in this instance, when you see that second bullet there, now think of the EMS agency, the ambulance service, saying, okay, well, we're going to operate at the technician or the clinician level. And then, of course, the next logical step is that the education programs have to require approval. So here's kind of a side-by-side that kind of shows what we laid out in rule. This is the technician kind of provides more of a ceiling or a cap to what these folks can do, whereas the clinician provides a floor and says, all right, well, here's the starting point, and how these programs are enacted at the local level is, much broader, a lot more latitude in terms of what it is that you're going to be doing as a program. Well, so here's a slide that says exactly what I just said. I probably don't have to bring this in, but I would say that the concept was to try to set something up, and I'm looking down at the last bullet there, something up that no matter what the size of the community, no matter what their level of practice or their scope of practice might be, whether they're EMTs, A's, I's, or P's, somewhere in there you could probably build a solution, whether there's a hospital involved or whether it's strictly a volunteer, whatever the case might be, is try to make it as permissive and with as much latitude as we possibly could. And that those folks depicted in that picture up there, that's the ambulance crew up in Albin, Wyoming. How do those folks, what does being a community EMS mean to a purely volunteer ambulance service in Albin, Wyoming? Who knows? Maybe they won't see a need for this in their community, but maybe they will. And if they do, we want to clear the path and make it possible for them to do that. So just real quickly, I want to touch on Medicaid as you work on building this in your state. Your state Medicaid office is your friend. If you can convince your Medicaid office that what you're trying to do with community paramedicine is the right thing, they have a powerful political stick that they can swing. The minute that healthcare financing jumps in on your side of the fray, you've got a strong ally. So we engaged Wyoming Medicaid right from the get-go, dating all the way back to making sure that I specifically invited them to the statewide stakeholder meeting that we had. Our state Medicaid medical director was there, participated in the meeting. He liked what he saw. Of course, he had seen numerous other things coming through email and different listservs where he was kind of sort of aware of it already. Boy, he grabbed hold of it and was an encouragement to me and a help. And what that resulted in, as that degree of interest peaked, was support out of the Department of Health, my bosses, in terms of getting this done and drafting it, because it's all about access to care, particularly in the rural states. and then how to pay for it. And when you make the connection and say, look, there might be a reduction in what Medicaid, an actual reduction in Medicaid expenditures if this all works right, that really causes folks to perk their ears up and pay attention. So just can't encourage you enough to engage with your Medicaid office early on in the process. To just bring that around, we're now the final rules that will allow Wyoming Medicaid to pay for the services provided by these agencies as they stand up. Those rules are sitting at the governor's office as we speak. He's a little delayed because we're starting our legislative session right now, but we're going to be able to start paying for this. We don't even have any of these programs really completely up and running yet, and we've already got the somewhat of a plan in place to start reimbursing folks for it. Out of that, there were some other benefits by establishing that relationship with Medicaid that we had not realized. We had some issues related to paying licensed ambulance services that were coming in and transporting patients, but they weren't licensed to be operating in the state. So getting the Medicaid help on that has been great. We were able to highlight our statewide EMS reporting, so that now in Wyoming, by the time we get to June of this year, if you send Wyoming Medicaid a bill for a patient that you transport, that report has to be in our statewide system. Otherwise, you're not going to get reimbursement. So that has helped bolster that. And then, of course, with that announcement that high-tech funding under the Affordable Care Act is now open and available to EMS, that we started that discussion as well. So go find these folks, talk to them, make them your friends. So what's this look like for us now in the next couple of years? Well, we're working hard on getting our real first program started. And the folks have already started attending the class in a kind of a shared program between Northwest College and Cody, Wyoming, and Hennepin College. So they'll be wrapping that up here before spring, that education piece. And I fully anticipate that Cody, Wyoming, which is a beautiful place to visit if you've never been there, that they'll be actually the first ones to kind of kick this off. They're going to be operating at the clinician level. That's a critical access hospital up in that area that fluctuates with the season when the Yellowstone National Park is open. So looking for good things to come out of the northwest corner of our state, and had some interest expressed out of the others. So how does the rest of it work in Wyoming? Well, I don't know that I really know the answers for that. I won't belabor those points because I've already made them. What's it going to look like in Albin, Wyoming, or Hewlett, or Baggs, any of the other dozens of small towns that are around the state? I don't know. I don't know how we work volunteers into this. I think there is a role for them. It's going to be difficult. I'm not a technical expert at establishing these programs. Like I said, I've never even functioned in one of these programs myself. So we're looking for some ways with the Office of Rural Health to try to figure out how we can get some expertise in and maybe set up a couple of pilot projects or system models that we can kind of learn some lessons. But I think the door is opened, and we've laid the good groundwork, and the next couple of years are going to be exciting for this. So bottom line secrets to success that I want you to take away. I don't put that first bullet in there to brag about me, but for sure, if your state office is not motivated to see community paramedicine happen, then that's going to be a tough hurdle. That helps when that one is already cleared. I can assure you, no matter where you are, that your state office is well aware of the concept. They've probably been involved in some discussions. They probably know Kevin and Gary. So I don't know how you solve that one individually. You got to approach it, got to make the argument. You can always give them my name. I'll be happy to talk to them. But having a state OMS that's motivated, that helps. The stakeholder meeting was foundational in bringing other folks along, not just the Medicaid folks, but local providers and the rest of it. That helps build consensus. establishing those relationships with people that have done this successfully or they're in the know. And in my case, at this point, that for sure is Kevin and Gary. I can't overstate what an assistance they were to me as we built this. So there are experts out there. Contact them, reach out to them, get their guidance, and see what worked for them. Whatever your state OMS relationship is with the Attorney General's office, mine is very good. I have two great attorneys that when I said to them, here's what I want to do, you got to help me get it done, and they were part and parcel to helping me figure out the methods to do that. And then beyond that, make some guesses. Who else out there might be interested in this? And over the course of the last 2-3 years, I've had conversations with all of the folks that I list there in Wyoming, our Medicaid Office, Primary Care Association, Hospital Association. Those are all partners as you work through this and can help you overcome those hurdles. So those are really kind of my big ticket items for the secrets to success. Okay, so if you want to read our rules, I've really glossed over a lot of the details because you're always welcome to read it yourself or send me an email. You can go to, this is a screenshot of the current Wyoming Secretary of State rules page. You just go there, hit that box that says current rules, look for Health Department of, and then Emergency Medical Services, and you're looking specifically for Chapter 14. And if that all else fails, just shoot me an email, give me a call. I'll be more than happy to provide what we have to you, and I can talk through some of the particulars and get you stuff in Word documents that are a little easier to amend and draft. And if anything I can do to help, just don't hesitate. So there's my contact information on the screen. Always welcome to reach out to me. If you've never been to Wyoming, please come visit us. We have a great state here. It's beautiful. I love being here. We do a great trauma conference, EMS and trauma conference, which is coming up in August, and I invite you all to register and pay your fees and come to our conference. It's a great little state conference with a small town feel. And with that, Kevin, I guess I'll turn it back to you, and I'll take any questions.
Super. Thank you very much, Andy. That was great. A great high-level look at what you have gone through to bring these rules into place. There's a couple of observations that I would make, and I would encourage Gary to pipe up. We did have a question in the chat box whether you had any requirement to testify at any legislative committee hearings. Since you didn't go through legislation, in your case that wouldn't have been the case. But anybody who is on the phone who has done that, the question was, are any of those possibly recorded for people to listen to in terms of hearing testimony, questions, and the like? But one of we have found in surveying state EMS offices that about 80% of the state EMS offices that have responded have said that they believe that their statute and or rules have been interpreted to enable community paramedicine to occur in their states. And that is by far better than we had anticipated a few years ago. Some have specifically gone out and done that, and others it's just sort of by happenstance. But one of the things that is commonly the most difficult barrier is when the State EMS Act is being cited as enabling only emergency practices, and that you have to go back in and either open the Act to allow non-emergency or go through some other machination to accomplish that. In Maine's case, as an example, we chose to create a pilot project enablement, which has actually become something of a long-term project, but we now have I think 14 or 15 different pilot projects going in the state, and community paramedicine is being provided. But one of the things that folks should do, even if they are initially told by the Attorney General's office or somebody else that their law does not enable this kind of practice, it's to do as Andy did, which is look in every corner of your enabling statute for any loose thread that you might be able to pull to get you around enabling CP or MIH without going in and opening up that statute, as Andy did. I think that folks that are careful about that and creative may find something that they didn't expect to have in their law. One other observation, and I would very much invite Gary's comment on this too, Andy's Wyoming's two-tier approach, the technician and clinician approaches, becoming somewhat more commonplace, and in fact, there are curricula evolving for both of those. I mean, obviously we've had the Community Paramedicine National Consensus Curriculum for a while, and the technician-type curriculum, shorter curriculum, has also been developed. And typically those are, as Andy indicated, aimed at that technician or lesser level, focuses really on things that the community paramedic can do, or community EMS technician can do on 911 calls to either employ alternative destination, patient delivery destinations, or to do treat and releases, to do things that are based on a 911 call that came in originally. The other level, the full clinician or full community paramedic level, is more seen as a sort of general practice community paramedic, somebody that goes out and provides care, goes out and does things that are not initiated not necessarily by a 911 call, but works with ACOs and health systems to do those services. We have a number of people on the call now who have a good deal of recent experience in this. Dan Swayze, I see, is on. Dr. Howard Backer in California is on. So I would invite any and all of them to make comments as well. So with that, Gary, can you unmute so that we can bring folks up? And at the same time, if you have some observations or questions you'd like to raise.
I think you did a good job, Kevin. The what I fondly refer to as the short course that Andy referred to as the Community EMS Technician course should be available later this month or early next month, and will be accepting students over to participate through distance learning. So we'll send information about that when it's ready. There are a couple of questions in the chat box. Kevin, do you want to do those first, or do you want me to unmute the lines?
Well, I'll pose those questions. Karen has asked, what type of role, if any, does home care and other providers play in providing community EMS? Have you gotten that far, Andy?
Excuse me. No, we haven't. So I don't really know the answer to, or how what that'll look like in the future, I guess I would say. You know, I think an important distinction here to remember from the regulatory side of the house is that I only regulate one profession, and that's the EMTs and paramedics that we license out of this office. And the other thing that I regulate is the ambulance services, the agencies that provide that. So in Wyoming, home health care, home care, and other, that's a separate licensing authority. We ran into an interesting problem when we started talking with those folks. You know, one of the, if I remember right, one of the early Colorado approaches was to develop to identify the community paramedic program as a home health agency. They were able to do that down there, although it was quite problematic for them to get that done. We quickly determined that was not really an option for us to identify a community EMS program as a home health agency because of the regulatory and licensing language related to home health agencies. And quite honestly, that regulatory authority was not interested in entertaining those discussions with us. So we really were forced to construct a new thing. So whether any other licensed professions would fold in the future, they most certainly could, but it would be under the auspices of the community EMS agency. So there's probably still some unknowns out there, and I hope that I answered your question, Karen. And then as to your other one your other question, why did you decide to open to all EMS providers? Can a clinician level be EMT or must be a paramedic? That's kind of a two-part question there. One being that open to EMS providers, if you look back at that workforce, in Wyoming, the ALS services where you're going to see the paramedics and even the intermediates, those are very tied to our largest populated centers, and that's about 5 across the state. So if you look back and remember that we got 97,000 square miles, the EMS agencies that end up servicing those areas on a day-to-day basis, they may not be paramedics. They may be EMTs or advanced EMTs or a Wyoming intermediate. So I was convinced that if we had left this just to the paramedic level, then we were never going to see any growth in delivering actual care into some of the areas that need it the most. Because what you've got going on simultaneously, it's the paramedic paradox that you've probably heard of before, where you need services the most, you can't get them. So what you've got going on in these rural areas is not only are there not paramedics, but there are people living there dependent on their local ambulance service to be at an EMT level, and I think it fits. I think it fits the concept of community paramedicine to a T. In that concept at its core is how do we take our licensed EMS workforce and use them in a role that they are not used to. They are not used to doing. And in many of these small towns in Wyoming, the only person who has any kind of healthcare training is the local EMT. And they're getting calls all the time about, hey, what do I do about this? I just got out of the hospital. So we felt we had to we felt like we had to open it broadly to try to get the maximum coverage that we could to try to make as much available as we could. Yeah, it'll look a lot different in small town Wyoming with a volunteer EMT level as opposed to Casper, Wyoming, or Cheyenne or Cody, where you might get a paramedic. But we wanted to say, okay, there's got to be a way that something can be done where nothing is getting done now. And as to the second part of that question, can a clinician level be an EMT or a paramedic? The answer is yes. It's a mix and match. So a paramedic could be a technician, an EMT could be a clinician, or vice versa. That was kind of the concept behind making it kind of customizable as to what the community felt that it needed and what it could go after.
And then there's a question above that from Mark Babson about the committee hearings.
Oh yeah, the committee hearings. Yeah, it's the way that we did this was through rule and not through statute. We only had to go through the rule promulgation process, which was the drafting of the rules and then putting them out for comment and then final promulgation. So there were no legislative hearings that were involved with that. Now, interestingly, another nuance in Wyoming law says that before I promulgate rules, I have to confer with all the ambulance services. So as part of the rule process, we did do a webinar on what this whole program was going to look like once these rules were published. And somewhere in digital world, we do have that recorded. That webinar is available. You're welcome to, if I can find the audio file somewhere, I'm certainly happy to make that available to whomever.
And I did a quick internet search after Mark posed his question, and it looks like the hearings in Minnesota may be archived. I can't listen to them until we disconnect here, but Mark, if they are, I'll send you links afterward.
Yeah, and if you'll send me an email, same thing, Mark. That'll remind me to look for the audio file somewhere and send it to you. I think we got it up on YouTube or Moodle or something like that.
And to Karen's question, just one other comment on the home care piece. I mean, obviously, mobile integrated health care is going to be one track that people can go down to involve home health and physicians and PAs and other folks in a consolidated administrative arrangement to provide a service. But two, there are examples, and Maine has at least a couple, in which a community paramedic service is actually dispatched by the home health agency without being a part of it. So none of the regulatory issues are raised. The CP program continues to be part of the ambulance service, but the home health folks that also are making decisions about dispatching home health nurses are actually doing the dispatching of those CPs, and that really goes a long way for improving those relations up front and making everybody partners as opposed to opposers in developing CP programs. Karen has another question. How does a consumer become eligible for services? What is the pathway to receive community EMS services? Are they referrals from PCPs? Are they driven by the EMS service? Andy?
Yep. So the first thing I would say is remember that we're still way early in this game in terms of getting these programs up and running. As we sit and talk today, we really don't have a program that's up and actually making this happen. So part of the answer to your question is, I don't know. But I think that the real answer lies in that when the way that we constructed these rules, we're kind of leaving it open to the programs to figure out. I think all of those things that you just mentioned are certainly possibilities as these local areas design how their programs are going to function. Remember that for community paramedicine, one of the key principles is that we're not duplicating services, and that the community paramedic and the community EMS organization is integrating with all those things that you mentioned, the primary care providers and local agencies, the local hospital, and the rest of it. It'll look a little, I'm certain that it'll look a little weirder on the kind of the more the technician side, the 911 focus, because there you're being a little more reactive than on the clinician side where we're being proactive. But I hope I answered your question, Karen, that all of those could be, I think they could be built in and integrated and would be allowable under what we've constructed, because that's really, to me, that's really for the community and the program to figure out about what's going to work best in their area.
Okay, thanks, Andy. Hey, Gary, can you open up take the mute off of folks' lines so that we can just have
The conference has been unmuted.
Okay, so I would invite anybody on the line to pose a question for Andy or comments if you have comments. It's going to be like that, is it? I thought I had an EMS audience here.
Hello?
Yes, please.
Yeah, this is Karen from Colorado.
Hey, Karen.
Sorry, we have so many questions. We're just right in the process of writing rules for our community paramedicine program, and so that's why we have so many questions.
That's fine.
So when you were talking about working with Medicaid on the reimbursement, were you able to, do you think, it sounded like you think you'll be able to get Medicaid reimbursement for the EMS agencies when they provide these types of services, or do you know yet?
Yes, we will. What we were able to do is I was drafting the EMS rules for how these folks were going to function. Medicaid the Medicaid office was able to say, all right, look, I've got a 70 or 80% plan here, and here's kind of what I'm thinking. And they came down, and over the course of it was a relatively short meeting, 2 or 3 hours maybe. I don't even think it was that long. Basically was able to map out kind of this bifurcated structure that we were setting up, how I thought it would work. They brought in their kind of resident rule experts on what existed currently in Wyoming Medicaid rules, and just by sitting and talking with them, they were able to ask questions back and forth, and they kind of rough sketched a map for what reimbursement would look like. And so the Medicaid rules are just about complete and sitting over at the governor's office now. But once they're finalized and these programs are up and running, then we'll have a mechanism where they can at least get Medicaid reimbursement.
And Karen, that's getting to be a fairly common experience. I know North Dakota is just going through that as well. Maine has, and we actually had the same kind of experience that Andy did, which was that it was going to go through very easily. Unfortunately, we have a political atmosphere in Maine that is confrontational between the governor and the legislature, so that's kind of got us stopped. But as far as Medicaid itself was concerned, they were gung-ho for this and saw a number of different ways that community paramedics could actually help the health department office that has Medicaid embedded in it. Now, the folks that started this were in Minnesota, and they had the first Medicaid rules that enabled reimbursement for CP. Minnesota went through a fairly lengthy process of actually writing that into their state statute and enabling CPs in statute. What we're finding is that other states probably don't need to go to that extreme, that if they can get their Medicaid office talked into including those providers as being eligible to be reimbursed, which, as a result of the 2013 Medicare or CMS rules change or change in their manual, now allows that to happen. The Medicaid office can go ahead and make those provisions, and they still have to change their Medicaid plan, which requires a CMS sign-off on it. But, again, Minnesota has gone through that process already, and so CMS is familiar with that and some other states that have gone through that. So the barrier has come down quite a bit. Other questions?
Hey, Kevin, this is Mark over here with Ada County Paramedics. And Andy, I was hoping you could speak to a little bit. You mentioned the webinar that you delivered with regard to these rules to the different ambulance districts or EMS authorities. I apologize. I'm not sure which one you mentioned. But if you could speak a little bit to the strategy that you employed to build consensus and support between the varying EMS agencies while you were doing this. Was there, would you have any recommendations or suggestions for success as well?
Yeah, sure. My experience, for starters, is that the paramedics and EMTs in Wyoming themselves were motivated to do this for whatever reason. I mean, they'd started hearing about it. They go, various conferences or whatever the case might be. So they were bringing it back. Whether they were conceptualizing it the right way or what their motivations would be, completely, might be different than mine. A lot of them saw it as an expansion of scope of practice and that sort of thing. But nonetheless, they were motivated to learn about it. And so I had a fairly fertile ground in terms of building that consensus. I'll tell you one of the things that really got it going, it's hard to believe that it's been, I don't know, it was 3 years ago now that we did the statewide stakeholder meeting in conjunction with our statewide conference, and that really helped get a lot of things spinning. We did about an 8-hour workshop. Both Gary and Kevin, Chris and Ann Montero were there. I can't even remember the different players that got involved there, but at any rate, having those folks come out and then me promoting it to the EMS agency saying, hey, you ought to take a look at this. Come down and get a chance to see what you might be able to do differently or better. And that was the meeting to which I invited the Medicaid folks and the Primary Care Association folks. And that really set a good groundwork, because coming out of that, people said, well, when are we going to do this in Wyoming? I said, well, now I've got a lot of legwork I've got to do in order to make this happen. So I would tell you that was a key to success. So having the fertile ground already, doing the statewide meeting, and then I have an advantage over many of my counterparts in other state offices, because while Wyoming is a very large state geographically, it's a very small state in terms of the number of EMS agencies and providers. So I know almost every ambulance service director by name. They all have my cell phone number. So that makes it very easy for me to contact folks and say, hey, have you thought about this? What are you looking at? Did you get this invite? Did you come to this meeting? In many states, that's tough when you've got, a couple of hundred EMS agencies. But those are some of the things that worked for me. So you can carry that back with you.
It's a great question, Mark. Thank you, Andy. Statewide stakeholder meetings, for those of you that haven't had those, or if you do it on a regional basis, there are a couple of things that we found that have been helpful with those. One is bringing in outside gunslingers, whether it's a Gary or a Mike Wilcox or Dan Swayze or Kevin Gienapp, who can address particular issues in terms of the successes of community paramedic programs. Bringing in somebody like an Ann Montero, who's a nurse, can also help with addressing issues from nurses, or Mike Wilcox as a physician, are very successful. But I think one of the things that you really need to think about is, if you're going to do a stakeholder meeting of that sort, you want to invite not only the people you think are going to love the idea or just be interested in the idea, but also the people that are likely to hate the idea, because that's a good first mixed audience to get those issues out and voiced, and get them addressed by folks who have been through this, more than once. So just some thoughts on that. Other questions or comments? All right. Andy, any last words?
No. Other than I'm just as curious as everybody else to see how this will develop in the next 2 to 3 years. Like I said, I've got some ideas. I've got my eyeball on a couple of small locales. I'm really, really interested to see whether or not we can get something like this up and running in a small town that doesn't have a hospital and they're relying on a volunteer service. I really think that when you're talking about community paramedicine and this kind of new role, you're going to see this this is the future of our industry, period, whether we like it or not. We have to confront it. We have to address it. We got to do it right. But this is going to be part of our future. So my many thanks to you guys for inviting me to present this. And certainly anytime anyone wants to contact me, just reach out and give me a holler. I'll help out whatever way I can.
That's great, Andy. And again, we thank you for this enlightening presentation, and do encourage everybody to encourage those who have an interest to contact Andy to find out more about his rules, his comprehensive rules change. As I said at the outset, I think this is one of the more complete set of rules that really address all of the different components of establishing community paramedicine, and so I really would hold it out as a good example. So that about does it for the January installment of the Community Paramedicine Insights Forum, brought to you by National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Learning, Innovation, and Research in EMS. I want to thank all of you who attended today for taking some time from your holiday day to do this on behalf of Gary Wingrove and myself. We will be returning. Again, we will not have a February session because, again, that conflicts with a holiday, but we will be coming back on March the 20th with our next Community Paramedicine Insights Forum. So thank you very much, and have a good week.